Okay, the incidence of ectopic pregnancy is about 2% of all of pregnancies. It's poorly understood, but thought to result from abnormal transport of the fertilized ovum and probably some local abnormalities in the tubal environment. So greater than 90% of ectopic pregnancies occur in the extracorneal portion of the fallopian tube. They also can occur at the fimbrial end, in the interstitium, or the cornu. We also see them in the ovary, although rare, within the cervix, and they also can be within the abdomen. Although the classic clinical triad includes pelvic pain, vaginal bleeding, and amenorrhea, this is only present in about 45% of patients, and up to a third of patients can have no clinical signs or symptoms at the time of presentation. So it's important to look at our role in this situation and how useful ultrasound can be in helping diagnose ectopic pregnancy. Risk factors, just to be complete, include anything that damages the tube, including prior infection or surgery most commonly. Infertility, a history of endometriosis, a history of prior ectopic pregnancy, congenital uterine anomalies, a history of intrauterine devices, and smoking all round out the list for risk factors of ectopic. So what do we do with these patients? So they come for clinical evaluation, and we first confirm that they have a positive HCG. Oftentimes we have no idea what the level is, we just know the patient is pregnant, and it's our role to perform a transvaginal ultrasound. And one thing I want everyone to remember, that we should all remember, is that no single measurement of HCG can identify the location of the gestational sac. A study we performed at Brigham and Women's Hospital showed that in ectopic pregnancy, there's a positive ultrasound finding in almost 95% of the cases. It's important to note here that the most common finding is a nonspecific adnexal mass. We can sometimes see an echogenic tubal ring, a yolk sac being present, and sometimes even a live embryo, although this is less common these days as we scan these patients earlier and can see things quite well. It's also important to note that a very small percentage of the time the only finding may be free fluid within the pelvis. So let's look at some examples of these findings. Here's a classic case of a patient who did present with the classic symptoms of pain and bleeding, and you can see this about 4 centimeter circumscribed mass that's sort of heterogeneous sitting in the left adnexa in a patient with nothing in the endometrial cavity. You can also see here there's a little bit of free fluid, and this is a nonspecific adnexal mass in a patient with a proven ectopic. Sometimes, if you look closely, you can see a small echogenic tubal ring, and inside here you can see there's a small yolk sac. So the likelihood of ectopic pregnancy here is quite high. So let's look at this case for a second. This is a patient who had undergone infertility treatment. What might not surprise you is there are multiples sitting here outside the uterus, out in the left adnexa. So if you look closely, here you can see the normal ovary with some small follicles, and next to it an echogenic ring, and inside you can see 2 yolk sacs and 2 live embryos in this live twin ectopic pregnancy. What about this case? Here you can see the normal ovary again in the still image, and a small amount of free fluid you'll see off to the side here. Next to the ovary you see an echogenic area with some complex internal material. And on further probing during the ultrasound exam, you can move this mass away from the ovary, and if you look closely you can see a yolk sac and an embryo and another live ectopic pregnancy, which is separate from the ovary. So how good is ultrasound? Well, the literature tells us that ultrasound is an excellent test in the evaluation for ectopic pregnancy. In fact, if you see a live embryo outside the uterus, the likelihood is 100%. But even if you just see an adnexal mass, the likelihood of ectopic pregnancy is greater than 90%. So if you're scanning these patients and you see an adnexal mass, you can be very confident in making the diagnosis of ectopic pregnancy. However, it's important to keep in mind that about 25% of the time we may not see an ectopic at the time the patient comes for the first scan in early evaluation of pregnancy. So along the same lines, it's very important to follow up these patients to make a diagnosis, because just as a normal intrauterine gestation will grow, so will an ectopic pregnancy, with the hope being that at follow-up scan we can make the diagnosis. So let's look at some common potential challenges that we see in evaluating patients in early pregnancy looking for ectopics. And these include large volumes of blood clot, identifying a corpus luteum, trying to differentiate that from a tubal ring of ectopic pregnancy, maternal fibroids, stimulated ovaries, and then also some maternal factors during scanning. So this is an impressive case. This is a 25-year-old woman who presented to our emergency department with pain and bleeding and was found to be pregnant. And as you can see here, there's a very large volume of blood and clot in her pelvis, actually lifting the uterus up out of the pelvis with all this clot. And if you look closely at the endometrium, we see no fluid collection within the uterus. On a coronal view through the uterus, you can see the complexity of the appearance of her pelvis. The ovaries are somewhere within here, but they're inseparable from all this clot. So in this situation, we can't really say where the ectopic pregnancy is, but we're very suspicious for ectopic pregnancy. And given the large volume of blood, this patient went to the OR for the surgeon to take care of the ectopic and to treat her bleeding. What about the corpus luteum versus a tubal ring? Well, they can look very similar. They both can be thick-walled, echogenic. They can have internal debris, and sometimes it can be very difficult to differentiate one from the other, although very important. So a couple things have been described that may help us differentiate the two, including the relative echogenicity of the tubal ring, which is likely to be more echogenic than the ovary itself. I've read that anechoic central fluid is more likely to be seen with a corpus luteum, but I think we all know that it can also be more complex. And probably the most important or helpful item would be being able to move the mass separate from the ovary, with the thinking that the corpus luteum is within the ovary and ectopic pregnancy is next to the ovary. Other items that have been described are the thickness of the wall or the appearance of Doppler flow or the quote-unquote ring of fire in evaluating a tubal ring or corpus luteum. And these are not particularly helpful because there's considerable overlap in the two. So let's look at some classic examples. So here's a nice case. Patient comes for early evaluation of pregnancy. There's no sac or fluid in the uterus, and here you can see the left ovary with some follicles and a well-defined echogenic tubal ring medial to the ovary. So it's very helpful to apply transducer pressure, because in doing so you can see there's a cleavage plane. Here's the tubal ring, here's the ovary, it moves separate, and you can be confident in the diagnosis of ectopic pregnancy. They're not always that easy, as you know, or you may know from clinical practice. Look at this case. So if you evaluate the left adnexa here, you can see the ovary sort of sandwiched in between these two echogenic thick-walled structures. They both seem to have similar echogenicity and complex internal debris, so it may be hard to determine which is which. And I'll just tell you that this is the ectopic pregnancy in this case, and this is the corpus luteum. But if I told you the inverse, you might just as well believe me because they look very similar. So the point is, it can be difficult sometimes. Another potential pitfall is maternal fibroids, and I know this very well from experience. Broad ligament fibroids or even exophytic body fibroids can be potentially confusing when looking for an adnexal mass. One thing that may be particularly helpful is looking at a prior ultrasound, because if these fibroids have been documented, you can save yourself the trouble of making an incorrect diagnosis. Look at this case, for example. In the right adnexa, you see a round adnexal mass. This one tends to be a little bit more hypoechoic. There is some free fluid, and this was a patient presenting for evaluation of ectopic pregnancy. We had the benefit of prior ultrasounds showing this to be a stable mass, and this was just a broad ligament fibroid. But you can see how that could be potentially confusing. Just to show you another appearance of a broad ligament fibroid, it can also appear more echogenic, like in this case. Here you can see the normal ovary with follicles, and next to it an echogenic round mass. With transducer pressure, it moves separately from the ovary as one would expect. But again, with the benefit of prior films, we know that this is a broad ligament fibroid. Just something to be aware of. Another potential challenge that we may encounter is in patients that have undergone IVF treatment and have stimulated ovaries. As you know, they can be quite large. And in fact, after patients undergo retrieval, those follicles can become thick-walled with debris inside, and they can have hemorrhage. And it can be very confusing in looking in the adnexa in that case for a tubal ring or an adnexal mass. I think this example points that out nicely. This is a patient who presented with pain after undergoing IVF treatment, and you can see on this transabdominal clip that there's a normal intrauterine pregnancy. Also note that the ovaries here fill the adnexa on both sides, as she had undergone stimulation of her ovaries. The patient's pain persisted, and she returned 2 days later for further evaluation. When we put the probe down, the first thing we notice is a moderate amount of blood in her pelvis, as you can see here, this complex fluid. And within 2 days, this adnexal mass had grown to the point where we could now see it, and you can see this echogenic adnexal mass sitting on the right side. On the real-time clip, you can appreciate the amount of complex fluid, the adnexal mass, and the presence of the intrauterine pregnancy. So this was a heterotopic pregnancy diagnosed at follow-up in a patient with persistent pain. The last thing I want to mention is that sometimes maternal factors can complicate our exam, including maternal body habitus, the orientation of the uterus, and sometimes just technical factors. So a poor visualization of the endometrial cavity is not acceptable. It's our job to make sure that we bring the patient back to do further evaluation, because you can't really include or exclude ectopic pregnancy or intrauterine pregnancy for that matter if you don't have a good look at the endometrium. So follow-up is very important. So let's talk for a moment about how we report these cases. So if a patient presents with a positive pregnancy test and the ultrasound is negative, we use an ectopic template. So you have to keep in mind that ectopic pregnancy is in the differential diagnosis, along with that it's too early in an intrauterine gestation or it's a failed early pregnancy. Because remember, about 25% of these patients, we may not see anything at the first scan for ectopic pregnancy. So close follow-up is always warranted. But sometimes in ectopic pregnancy, the findings may be kind of confusing. So endometrial fluid is sometimes seen when evaluating these patients in early pregnancy. So what do we do with that fluid? So when you identify endometrial fluid in early pregnancy, it's very important to assess the characteristics of the fluid and place the fluid into one of three categories. Presence of a yolk sac or an embryo, if the fluid has pointy edges or is echogenic and conforms to the shape of the cavity, or if the fluid looks rounded or anechoic and cyst-like. So what I'd like to focus on now is, what if you see this fluid that looks echogenic, conforming to the cavity shape, in a patient being evaluated for early pregnancy? Well, one thing that I would also like to reiterate is when you see this type of fluid, it's very important to avoid the term pseudogestational sac. The fluid that we see within the endometrial cavity is not sac-like in shape, it's not sac-like in appearance, and in fact, it's not a gestational sac. So when we see it, we can describe it and make sure we follow the patient up appropriately. But I want to make a point here again to not use the term pseudogestational sac, because it can lead to errors in diagnosis and treatment. So I'd like to show some examples of fluid in patients with diagnosed ectopic pregnancies. So in this case, this fluid is expanding the endometrial cavity, and you can see it has a pointy edge here. This does not look like a sac, and in fact was endometrial fluid in a patient with ectopic pregnancy. Here's another example showing the passive echogenic fluid distending the cavity, and a small amount of free fluid was also present in this patient with known ectopic pregnancy. And here's a third example of some echogenic clustered debris within the endometrial cavity in another patient with ectopic pregnancy. So once we make the ultrasound diagnosis of ectopic pregnancy, what happens next? Well, these patients can be triaged into one of three categories. If the patients are clinically stable and their HCG is declining, they can just be followed expectantly by their obstetrician. However, if the adnexal mass is of a certain size and the patient meets certain criteria, they can be treated with medical therapy. So if the adnexal mass is less than 4 centimeters, the HCG is less than 15,000, and the patient is stable and able to complete follow-up, these patients can undergo medical therapy, which is intramuscular injection of methotrexate. In some situations, however, like that early example of the young woman in the emergency room, this is not possible. So if the patient has severe pain, obviously, peritoneal signs, moderate or large volume blood in her pelvis, a falling hematocrit, a very high or higher than 15,000 HCG level, or an adnexal mass that is larger than 4 centimeters, these patients typically have to be treated with surgery. Other situations where medical therapy is contraindicated include liver or renal failure, unable to complete follow-up, the presence of a coexistent intrauterine pregnancy, the desire for surgical sterilization, or a patient that is breastfeeding. So let's shift gears a little bit now for the second portion of the talk to look at what we call unusual ectopic pregnancies. Although uncommon in pregnancies conceived naturally, we do see them in higher amount in patients that have undergone assisted reproductive therapies. Unusual ectopic pregnancies include those that occur in the cervix, within the interstitial portion of the uterus, and we'll talk about heterotopic pregnancies. These are very unique in that they are not amenable to the standard therapies for tubal ectopic pregnancies. In fact, the patients are at increased morbidity for bleeding based on their location, and they have decreased response, like I said, to tubal therapies. The treatment goals are to provide an alternative to methotrexate in invasive surgery for these patients, to preserve the uterus for potential future pregnancies, and furthermore to preserve the intrauterine gestation in patients that have a concomitant intrauterine pregnancy. So let's talk about cervical ectopic pregnancy. So as you can imagine, the cervix is a very poor environment for placentation to occur, as it is mostly connective tissue. And the risk of severe bleeding is significant in these patients, which puts mom at quite high risk. We make the diagnosis of cervical ectopic pregnancy when you see a well-formed round or oval sac within the cervix. You can see a prominent echogenic rim and the presence of an embryonic heartbeat. The main differential diagnosis is a spontaneous abortion in progress, in which case you are more likely to see a flattened shape of the sac and a thin echogenic rim around the sac. So let's look at a few examples. Here's a patient who presented for early evaluation of pregnancy, and here you can see on this transvaginal sagittal view of the uterus this sort of dumbbell-shaped, somewhat flattened sac within the endocervix. On first evaluation, we weren't sure, is this a pregnancy on the way out, or is this actually sitting within the cervix? How are we going to manage this patient? So if you apply some pressure with the transducer, it's kind of confusing actually. I feel like the sac sort of maintained its shape, and it did not slide relative to the endocervical canal. So we weren't entirely sure. So when you aren't entirely sure and the patient is stable, it's very reasonable to bring the patient back in 1 to 2 days, because if the sac passes, you have your answer. And if it persists, you may also have your answer. So this patient came back 2 days later, and we saw the interval development of a heartbeat, making the diagnosis of cervical ectopic pregnancy. Sometimes it's a little bit easier. Here's a more classic example where you see a well-formed oval sac sitting within the cervix. When you scan through the endocervix, you can see that there's a thick echogenic rim and the sac maintains its shape. And the other trick we have, like usual, is to apply pressure with the transducer to see, is that sac going to move or is it going to stay put? And you can see here, when we apply pressure, the sac doesn't go anywhere. So in this case, we were able to diagnose cervical ectopic pregnancy at the time of her presentation. Treatment options include uterine artery embolization or cervical curettage, methotrexate regimen, potassium chloride intrasac injection, or a combination of both systemic and local therapy. And the advantages here are to avoid hysterectomy for the patient, which used to be the standard of care. Such as in this case, you can see on this dated ultrasound from the 1980s, you can see the presence of a gestational sac sitting within the cervix. And this is how the patients were treated. I guess this was over 30 years ago now, but there's a hysterectomy specimen from that particular patient. We know that systemic methotrexate alone has very high failure rates in cervical ectopic pregnancy. So we can offer in ultrasound the guidance for local intrasac injection of either potassium chloride or methotrexate, which can be performed by itself or in concert with systemic therapy for the patient. So ultrasound-guided local intrasac injection is performed ideally early in the gestation, usually before 8 to 9 weeks, and is performed with a 20-gauge needle that's approximately 20 to 25 centimeters long. So this is performed with the obstetrician in the ultrasound suite with the transvaginal needle guide in place, and the OB will advance the needle under our guidance into the sac and inject either 2 to 5 milliliters of potassium chloride or 25 to 50 milligrams of methotrexate into the sac. Features associated with high failure rates include the presence of a heartbeat, later gestational age of greater than 9 weeks, or HCG levels of over 10,000. Let me show you an example here. This is the same case of that sac that we see sitting within the cervix, and you can see the needle guide is in place. On the second image, you can see the needle puncturing the sac. And here in real time, you can see the air being introduced into the sac from injection of the potassium chloride. So this was the treatment for that patient's cervical ectopic. Moving on to interstitial ectopic pregnancy, you can see from this diagram why the interstitium of the uterus is a very poor place to support a pregnancy. As you have both the ovarian and the uterine arteries coming in here, it's a very high-risk situation to carry a pregnancy. The ultrasound diagnosis of interstitial ectopic pregnancy is made by looking at the characteristics and the location of the sac. The most helpful rule is looking that the sac is in the cornu of the uterus, however it is separate from the endometrial cavity. It is not encased by endometrium, and in fact there's little or almost no myometrium at the lateral edge of the sac. 3D ultrasound is particularly helpful in this situation, as well as using transducer pressure while scanning the patient, as the differential diagnosis includes tubal ectopic pregnancy and also a normal intrauterine pregnancy that may just be eccentric to one side of the uterine cavity. So this case is particularly instructive, I felt. If you look here, you can see the left ovary, and next to the left ovary you see this adnexal mass, which is rounded in between the ovary and the uterus. So at first glance you might think this is a run-of-the-mill tubal ectopic pregnancy. However, when you use the transducer and put pressure on this mass, you can see that it moves with the uterine cavity and it's separate from the endometrial cavity. And on a 3D image of the uterus in this patient, here you can see the interstitial location of the pregnancy sac separate from the endometrium, proving that this is an interstitial ectopic pregnancy. Let's look at a companion case. This is a patient who also presented for early evaluation of pregnancy. And as you can see, there's an intrauterine gestational sac off to kind of eccentric to the left, way up in the cornua or interstitium of the uterus. You don't really see much myometrium at the lateral edge of it, and at first glance you may wonder, is this an ectopic pregnancy in the interstitium or is this within the endometrial cavity? So if this patient's stable, you can bring the patient back if you're not sure. In this case, we did a 3D ultrasound sweep of the uterus, which you can see on this image shows that pregnancy sac is actually within the endometrium. So this is an intrauterine pregnancy, not an interstitial pregnancy, which is a very important differentiation to make, as this patient came back at 24 weeks with her normal intrauterine gestation. So to summarize the treatment options for interstitial ectopic pregnancy, they include ultrasound-guided local intrasac injection with a 20-gauge needle passed into the sac under ultrasound guidance, or systemic methotrexate therapy. You can use a single or multi-dose regimen, and it can be performed alone or with local intrasac injection. Here's a case of a live interstitial ectopic pregnancy. Again, this looks very similar to the last case. You can see an embryo, though, here with the heartbeat sitting in the left interstitium of the uterus. On the first image, you can see that the transvaginal needle guide is in place. The needle is being advanced into the sac, into the embryo. And on the last image here, you can see the injection of the KCL to treat the interstitial ectopic pregnancy. Keep in mind that it may take some time for the appearance of those pregnancies on ultrasound to resolve. So these patients are also followed closely after treatment of their unusual ectopic pregnancy. In our remaining time, I'd like to say a word about heterotopic pregnancy, which is defined as the coexistence of an intrauterine and an ectopic pregnancy. The treatment goals are to preserve the intrauterine pregnancy and to eliminate the ectopic pregnancy. Here's an example. On this transabdominal view of the uterus, you can see a normal intrauterine gestation with a heartbeat, and out here on the left side, you see this echogenic thick mass in the interstitium, which is an ectopic pregnancy at the same time. Treatment options include laparoscopic salpingectomy if it's a tubal ectopic. However, if it's an unusual ectopic, we can offer to these patients local intrasac injection of KCL, passing the 20-gauge needle again into the sac to treat the ectopic pregnancy. Keep in mind that methotrexate is not an option in this case because of potential damage to the normally developing intrauterine pregnancy. So here's an example. Here you can see the interstitial ectopic pregnancy and the needle guide in place, the needle coming into the sac and injecting KCL to treat this patient. So in conclusion, I would just like to say that ectopic pregnancy is not uncommon and that ultrasound is essential in the clinical evaluation. Oftentimes findings may be confusing or we may be uncertain, and in these situations it's very important to bring the patient back if they're clinically stable. In reporting these examinations, when you see a negative pelvic ultrasound, keep ectopic pregnancy in the back of your mind and as an option when discussing these cases with a clinician. If you see endometrial fluid, it's important to assess it and avoid the term pseudogestational sac in your reports. Keep in mind too, if there's poor visualization of the endometrial cavity, that we need to follow up these patients to be sure that we can accurately diagnose their intrauterine gestation or ectopic pregnancy. And lastly, we discussed management of both tubal and unusual ectopic pregnancies. Ultrasound diagnosis can help triage these patients into medical versus surgical management, and furthermore, ultrasound may play an important role in therapy of unusual ectopic pregnancy.